Hi, I'm Dr. Scott Worden, the TOS guy from beautiful downtown Sunnyvale, California, right next door to Cupertino and the Big Apple Spaceship Campus. Welcome to our talk today. Number one, please mash that like button. We get a big boost when you people tell us and tell YouTube that we're helping you out. So it really helps spread the word to future patients as well, and we appreciate it. And if you haven't, please subscribe. We have we're recent a lot of growth. We're over 1,700 people subscribing, and we really appreciate that. And again, it helps push the algorithm from YouTube forward so more people find us, and especially those are patients who we haven't met yet, and it's really important for everybody. Now, today we had a talk scheduled with Dr. Vernon Williams from Southern California, and unfortunately, he's at Cedars-Sinai Hospital. He was not able to make it today. This is what happens when someone like him is in so much demand. But we will have him back soon. And instead for today, we're going to do a quick hitter of 5 key questions that people often ask us about TOS and that we feel are important. So we're going to keep this short and to the point. Let's start with our first question. Why does it seem like TOS is not diagnosed like other common diseases? So this is very interesting. One of my pet peeves about this, for obvious reasons, is that docs don't use enough imaging for TOS. It's a disease of anatomic abnormalities, and albeit complex, we still know that there are many variants, many anatomic abnormalities people are born with or they acquire over life. So I always talk about the example, the historical example of appendicitis. It used to be when I first started training, which isn't that long ago, that we would have 15% false positive and 15% false negative rates when a doctor would examine a person for appendicitis. And this can frequently affect younger people. So it was an important diagnosis to get correct. 15% false negative and false positive means 15% of the time a surgeon would go in, 15% of the time a surgeon would go in and do surgery for a patient who did not have appendicitis. Then 15% of the time a surgeon would not go in because he or she did not believe the patient had appendicitis, but in fact they did. In the late 1990s, a radiologist came along in Massachusetts General Hospital named Rao, R-A-O, and he applied CT scanning to this problem, and bang, everything was so much better. Now we get about 3% false negative and false positive together, about 97% accuracy when we do a CT scan of appendicitis. So that means we've gone from 15% down to 3%, or an 80% reduction in false positive and false negative. And I can tell you the appendix is located all over the abdomen and pelvis in different people. So to know where it is anatomically is a key element. And if you don't know the anatomy, then when you examine a patient, you don't know that you're pressing on the appendix or pressing on something else. So we do the same thing with TOS. Our Nia Vista scan and any reasonably done MRI scan from somebody who knows how to read it can tell you, the patient, and your doctor what anatomy is happening in that area that's critical to know. And because there are so many variants of the disease, your surgeon would probably want to know what he or she is operating on, how they're going to address it before they go in, not just to go straight in and figure it out on the fly. All right, what's our next question? I've been recently clinically diagnosed with TOS. Is a good next step ultrasound or MRI? Now, we're big fans of MRI here. I do lots of ultrasound for all kinds of other diseases, as do most radiologists. But ultrasound has some challenges. First, I'm going to talk about ultrasound's benefits. It is live, real time. If you're a radiologist and you go in the room and you do ultrasound of a patient, or you watch while your sonographer, who's usually more skilled, does an examination, you can see things as they move. It's like a video game. It's great for blood vessels. You can look at the blood flow in the veins and the arteries and see how they change when you move the patient's arms or neck. That's pretty valuable. But the vast majority of TOS cases are neurogenic TOS, where the brachial plexus is compressed. And the spot where it's most frequently compressed is between 2 bones. And ultrasound does not go through the bones. So ultrasound is very limited in one of the most critical areas. In addition, there's a lot of anatomic variation of the soft tissues, like the scalene muscles. And the brachial plexus, which is soft tissue, goes through the scalene muscles or around them or behind them in many different variations. This has been known for 100 years. So ultrasound has trouble distinguishing those nerve roots from the muscle and doesn't allow the full layout of the anatomic variability, which is important for knowing how to do surgery if surgery is needed, or even before that, how to make the diagnosis. So ultrasound is limited, separating soft tissues from one another, but it does have the advantage being good for blood vessels. Now, 95% of cases that are neurogenic TOS may have some involvement of blood vessels, but by far, the most important thing is to see the brachial plexus and all the tissues that surround it, from fibrous bends to extra muscles, to the nerves going through the muscles, between the collarbone and the rib, all the way out to the shoulder. And MRI is great at showing all of this differentiation of soft tissue. With MRI done the right way, as we do it at Nia Vista, we can get pictures of the arteries and the veins as well as the brachial plexus, as well as the muscles, the fibrous bands, the lung, the bones, and we do it in two different arm positions. So we're actually measuring the motion of the major bones of the shoulder while we get these anatomic images. MRI, to me, is clearly the best test to get that full lay of the land of, do you have TOS? And if so, what are the causes? What's our next question? Should I be concerned with muscle weakness just after being diagnosed with TOS? Simple answer is yes. The muscles usually don't get compromised until there's pretty severe or prolonged nerve damage. We had talked about EMG before, and we'll talk about it shortly here. But what happens is the nerves are composed of thousands of fibers. There are three main types. There are sensory nerves that bring things from the body back to the brain. There are motor nerves that send messages out to the muscles. And there is an autonomic nervous system that does things like control blood pressure and temperature, etc. So we're going to concern with the sensory nerves. Those are the ones that are smaller, and they don't have a myelin coating, and they're more prone to damage. And when you measure them with nerve conduction velocity, you don't see a change. You don't see a change on nerve conduction velocity until you get to the deepest 20% of those nerve roots. And those are the big motor fibers that have a myelin coat, and they're larger in diameter. And by the time you get to that level and you get a positive nerve conduction velocity, that means that the motor nerves are damaged, and then the muscles that depend on those motor nerves are usually smaller and weaker. Now, in many cases elsewhere in the body, when you have a nerve entrapment syndrome, as a doctor, you want to diagnose it quickly. You want to diagnose a neuropathy before it gets to weakness of the motor nerves. And that way, you can prevent irreversible damage. But if you wait too long and you have muscle weakness or atrophy, then you may not be able to recover all of that function, and that's obviously a disability that can go on a long time. Next question. Why is EMG not a good test for neurogenic TOS? Now, this is a test that doctors ordered in the past, and actually in the 1980s and 1990s, there was a big academic discussion in the literature about why patients with TOS did not have a positive EMG. EMG actually includes nerve conduction velocity as well as EMG. The technical details are not so critical. But the point is that patients get symptoms early on in the compression or stretching of the brachial plexus. They get motor problems where the muscles are weak or atrophied later in the course after the compression or tension has been severe and prolonged. Now, as I said, any other entrapment neuropathy, doctors will try to treat it before you get to that point of motor involvement. And it's no different for TOS. When the patient first gets symptoms, you want to treat it and stop it there before the motor nerves get involved. Now, nerve conduction velocity doesn't show an abnormality until the disease is advanced. And EMG shows what happens to the muscles. Their electrical activity depends on the nerves that are feeding them. Again, without the technical details, the important thing to know about the EMG test is that insurance companies will still order it, even though every TOS specialist I've worked with knows that the test is useless for ruling in or ruling out TOS. And in addition, even if you had a positive EMG test, it wouldn't tell you where the anatomic abnormality arose. And if a surgeon needs to go in because you have neurogenic TOS, then the surgeon should know what the underlying anatomy is. So EMG, positive or negative, does not obviate the need for good imaging, which helps the doctor make that clinical diagnosis. Don't be fooled. EMG is not the test to rule in or rule out neurogenic TOS. And we have one more question here. What are the three things I should be most concerned about after TOS surgery? So short term, You're going to worry about some simple things that generally occur in every surgery. Do you have bleeding, fluid collection, a fever from infection? In TOS surgery, you might get a small puncture of the lung, and the lung may partially collapse, something called pneumothorax. So chest pain or shortness of breath shouldn't be there. In the intermediate term, a lot of surgeons are using postoperative physical therapy to ensure that the nerves are gliding and the muscles are staying in shape and the flexibility is maintained. And this is important, but you don't want to be doing strengthening exercises. So gentle nerve gliding things to make sure the nerves don't get scarred down in the surgical bed. And then long term, even intermediate term, you may have changes in sensation. So immediately after surgery, you're going to have some local pain, but you should not be developing new nerve symptoms. For example, a patient who had tingling in their fourth and fifth fingers, that should be improved after surgery. But you should not develop tingling in the first, second, and third fingers. So a change in pattern of the nerve pain should not occur. Now, for any of those, you should keep in touch with your surgeon if you've had surgery, and that's the question we're answering right now. Your physical therapist may help with that, but in general, you're going to need your surgeon to take a look. And you may also need pain management specialists to help with that. So again, short term, typical postoperative things, including a pneumothorax or an air leak around the lung. Immediate, you're going to want to have a physical therapist help you glide the nerves, and you'll be regaining flexibility without strength training. And then long term, you don't want to have changes in the nerve pattern, because that suggests that there's some scarring going on that's now compressing other nerves and giving you another type of neurogenic TOS. I hope these 5 short questions and answers have helped you. These are ones that we get asked a lot, and we're going to take any questions that we may have here. Vladislav Kleiner, I hope I'm pronouncing it correctly. Do you know any good doctors in Europe, especially Germany? I do not know any in Germany. I know of some in England. If you reach out to us through our website, tosmri.com, we can connect you with some of those surgeons in England, and they may know other people closer to you, or maybe that's a more convenient trip for you to make. Thank you for the question. Tate, hi Tate. Really grateful for these talks. Thank you. Sadly, I can't stay long to watch tonight due to a meeting. Hope you'll be having another one soon. We really appreciate return patients like you. You always ask good questions, and we thank you for your support. And we're going to see if we have any other questions. And we don't have any more questions. Anybody out there want to ask one? Tate, again, just as I said, you were very supportive and asked good questions. If your hand goes white quickly when it's raised over the head, what does that indicate? That's a really good question. Some people believe that it means that there's compression of the artery when you raise your hands above your head. Now, in some patients, very few patients, they can compress the artery to a significant amount. Most patients will compress it a little bit. So a lot of normal people will compress the artery if they really stretch their arms. But there's something else going on here, which is, I mentioned briefly before, the autonomic nervous system. That is a subconscious nervous system that runs out and back to the brain. And it tells the body to control its temperature, to shift blood around. For instance, if you're outside shoveling snow and you're not wearing gloves, you can lose a lot of heat through your hands. So the autonomic nervous system would close down those blood vessels and try to keep the blood centrally in your chest and heart to keep it warm so you wouldn't get cold. If you affect that autonomic nervous system by compressing or stretching the nerves, it can act very funny and create unusual situations like your hands turning white or blue or red. There's also a similar syndrome that people talk about that may be connected with this. But again, it's all related to the autonomic nervous system, even if we can't always regulate it. There has been some there has been some evidence in the past that in some people, the autonomic nerves are more peripherally located, making them more vulnerable to compression around the first rib. So that's why some people, we believe, get these kind of symptoms and other ones don't. It would be vascular autoregulation rather than compression of the large vessels. Thank you for the good question. All right. We appreciate everybody hanging out with us. And we'll be doing a new talk with Dr. Vernon Williams soon. We'll put it on schedule. If you've subscribed, hit the bell because that will warn you and alert you when we have a new talk coming up. In the meantime, hit the like button, subscribe, and everybody have a great day. Again, this is Dr. Scott Worden, the TOS guy. Take care.